Moving on to our next topic, calling the chairpersons, Dr. Anil Kumar, who's the consultant physician and diabetologist, HOD and associate professor, Department of Endocrinology at Karnataka Institute of Endocrinology and Research, Bengaluru, and Dr. K.N. Harish Kumar, who's the family physician at Naveen Clinic, Bengaluru, past president of the FPAB.
After a good panel discussion, we have one more interesting topic. That's neuropathy beyond pain, what clinicians should know. To talk about it, I welcome Dr. Jyotirmoy Pal, Professor of General Medicine at KG Kar Medical College and Hospital, Kolkata. Welcome you, sir.
Thank you, Dr. Srinivas Murthy, for inviting me in this beautiful city of Bangalore. My topic is slightly break from the main theme of the conference, that is the cardio-metabolic conclave. I asked Srinivas, what is your expectation from this topic? He told, I want the approach to a peripheral neuropathy from the internist point of view, because he told all of us outer coating is diabetologists, but inside we are all physicians. And okay, so let us, for the time being 20 minutes, we all become the physicians. So peripheral nerve disease for the diabetologist means features of different type of diabetic neuropathy, burning sensation, different therapies, and to some extent intractable symptoms. Patient never become very happy, even after giving so many therapies, treatment, changing medicines, substance medicines. So let us see what should be the approach of a peripheral neuropathy when it comes to a physicians. First, let us start on two model case. This is case number 1. Carefully read. 52 years old man presented with slowly progressive weakness in the both lower limb for the 4 years, and weaknesses show that he has a difficulty in holding footwears and frequent tripping when there is when they are walking. For the last 2 years, he has weakness of the upper limb, mostly at the distal part of the upper limb, so there is a difficulty in buttoning and doing the finer walks, holding the cups, glasses, all these things. And there is a lack of sensation initially from the foot to extend to ankle and also in the hands up to the wrist. Later on, it has progressed in the lower limb up to the mid-thigh and upper limb also above the elbow. So that means there is a weakness of the that fellow, the lower limb, distal muscles, and also loss of sensation distally and proceeding proximally, starting from feet and the arms. On continued history, there is a no bowel bladder difficulty, no speech disorder, no disorder of the mentation, memory, erectile dysfunction, dizziness on change of posture. That common question is asked for the autonomic involvement. No history of dry mouth or eyes, and no, he has past medical history and personal family history, nothing significant, and no history of diabetes, though it is a diabetic conclave. On examination, we have found there is a wasting of the muscles of the lower limb below knee and weakness wasting of the upper limb also wasting. At the same time, there is a hypotonia and power is less, both lower limb and upper limb muscle, mostly at the distal part. Deep tendon reflex was absent and plantar was bilateral flexure. This is the presentation. So this is the motor examination. When done the sensory examination, it is shown that the both pain and temperature sensation on examination was reduced. Vibration position sense also impaired, and touch, both crude and fine touch, both are impaired. That means the spinothalamic sensation and posterior column sensation both are impaired. Now, before going to the discussion, now we are going to the case number 2. This is a 61-year-old male, strictly vegetarian woman, no significant history of past any diabetes, hypertension, any other. Presented with progressive unsteadiness of the gait over a 5-month period. And this increase in the dark light. For the last 3 months, he noticed tingling and numbness. There is a positive symptoms of the sensory involvement in her hands and feet. On neurological examination, again, higher function was not absolutely normal. Tone of the muscle was normal, rather slightly reduced. Reflexes absent at the ankle, but other knee jack and others was exaggerated. Plantar was extensor. Ankle absent, knee jack exaggerated, plantar is extensor. And he has a loss of sensation of the touch and vibration in the hands and feet, and also loss of proprioception. That means mostly the posterior caudal sensation is impaired, and Romberg sign was positive. So now question is from these two cases, we will go discussion later on, but now question to internist, when this type of patient will come to you, what is the localization? This is the neurological case, no doubt. So what is the neurological localization? That means anatomical localization. What can be the etiology, and what can be your provisional diagnosis? So 3 questions will come to your mind. So for the question number 1, when we come anatomical localization, first from the history and examination, we have to decide whether it is a element lesion or upper motor lesion or combined. For the first case, all the reflex was diminished, muscle loss, sensory symptom is there, and plantar is fractured. That means it is a lower motor type of lesion. In the second case, there is some features of the upper motor and some features of the lower motor. Both are present because plantar was extensor, at the same time ankle jerk was absent, and tone was diminished. So there is a second case, there is a combination of both upper and lower motor lesion. If it is a lower motor lesion, then your search will be whether it is a muscle disease, whether it is a disease of the myoneural junction, whether it is a disease of the peripheral nerve, whether it is a disease of the plexus, whether it is disease of the root or of the anterior horn cell. So if we come gradually, if it is the anterior horn cell disease, there will be only motor symptom, there will be fasciculation, there will be wasting, weakness, but no sensory symptom. But in this case, there is a sensory symptoms. So it is not a anterior horn cell disease. If it is a root, there will be root pain, either pure motor or it will be pure sensory. But here it is a combination, and there will be some root pain. The root pain is absent in this case, so it is not a root disease. Plexus, it will be the segmental distribution, patchy distribution involving of the particular segment, so it is not a plexus disease. So if we come to the muscle disease, there will be no sensory symptom. Here is the sensory symptom is there. So muscle disease also excluded. Myoneural junction, there will be waxing and waning character. Here it is not it is a progressive for the 4 years. So it is not also myoneural junction. So it has a both motor and sensory symptom. So it is a case of peripheral nerve involvement. In the first case, there is the lower motor, but in second case, there is both involvement of the upper motor and lower motor. Definitely peripheral nerve also involved in second case also. So from this understanding of the first case and second case, now in the 3 layer, we have to examine and analyze the patient in the 3 layer. First layer is what system is involved, whether it is a predominantly or purely sensory involvement, whether it is pure or predominantly motor involvement, what is the mixed motor and sensory involvement, or neuropathy with autonomic involvement. Second question will be whether it is a length dependent or non-length dependent neuropathy. Third, it is a small fiber or large fiber neuropathy. And fourth, what is the associated upper motor symptom present or not. This is the fourth question in the layer 1. So if you come one by one of this case, in the first case, there is a motor involvement because patient has a weakness and wasting, that is the atrophy of the muscle, clawing of the hand, piece cabas, hammer toe. These are the features if there is a motor involvement. In the first case, definitely there is wasting and weakness, so motor involvement is there. Sensory system involvement, there can be 2 types, one either positive symptom or negative symptom. Positive symptom means tingling and numbness, that indicate the partial damage. But if there is a complete damage, there will be negative symptom, that means numbness. So in this case, in the first case and second case, in both cases, there is a tingling and numbness is there. There is a positive sensory symptom is there. That means the partial damage of the peripheral nerve. Third is the autonomic nervous system involvement. Here mostly common history is dizziness from sitting to standing position, or loss or excessive sweating, or impotence, So lightheadedness, these are the, or bowel bladder disturbance, these are the very common symptoms of the autonomic nerve involvement. But here in the cases, there is no such a autonomic nerve involvement. So in case 1, basically element type of lesion have both motor and sensory fiber involvement because of the atrophy and tingling numbness of the hand and the feet. But in the second case, there is a both combination of upper and lower motor lesion, and here sensory fiber was mostly involved because atrophy was not there in the lower limb. So in the second case, both element and human lesion combination was there, and mostly the sensory fiber was involved because of the tingling and numbness symptom and loss of the proprioception and vibration, loss of sensation was there. So second question was whether it is a axonal degeneration or demyelination or the demyelinating disease. Second question, if it is a purely axonal disease, there will be more a distal symmetrical and glove and stocking distribution. That means distal, in the first case, it was the distal predominant, it was a symmetrical in both feet, and glove and stocking. That means when it has progressed up to the ankle, in hand also it proceed up to the wrist. When the lower limb, it proceed up to the mid-thigh. In here also, it proceed up to the elbow. So there is a glove and stocking distribution of the signs and symptoms. And also in less severe case in axonal, ankle jerk is absent, but knee jerk may be preserved. But if it is a purely demyelinating, there will be motor symptoms will predominate over the sensory symptom, and there will be global areflexia and thickening of the nerve. So if we summarize, in axonal cases, the pain and temperature will be more affected than the vibration and position sense, and distal will be more affected than the proximal. In demyelinating cases, opposite, the vibration and proprioception will be more affected than the pain and temperature, and proximal and distal will be equally involved. So case 1 is basically, it is axonal. Because in case 1, there is mostly the pain and temperature was more affected. But in the case 2, it is more a demyelinating because vibration and joint position sense was more affected, and patient has a Romberg sign positive. So case 1 is a more axonal, case 2 is a more demyelinating cases. Third question we have to solve whether small fiber involved or large fiber is involved. Large fiber is basically carry the posterior column sensation. So if there is a large fiber involvement, there will be more ataxia, imbalance in walking, and band-like sensation and vibration and position sense will be more affected. Very classical example is vitamin B12 deficiency. But in case of small fiber is involved, there will be more burning and painful sensation and more symptoms of the autonomic dysfunction, and joint position vibration sense may be impaired but less than the large fiber involvement. And small fiber, usually diabetes, amyloidosis, alcohol, drugs, HIV, these diseases usually involve the small fiber. That means if we summarize, small fiber is, if there is more burning sensation, that means there is a more small fiber involvement, and here the reflex is comparatively preserved. In the large fiber is involved, there will be more a numbness, and posterior column sensation will be lost, that is the vibration, proprioception, and reflex will be lost. So case 1, basically small fiber involvement because burning sensation was more, tingling numbness was more. But in the case 2, there is a more a proprioception, vibration was lost. So there is a large fiber involvement is more in the case 2. Next we have to take the history, and we have to come to a conclusion whether there is an involvement of upper motor. In the case 2, there is a upper motor involvement because plantar was bilaterally extensor. So the combined involvement of the upper motor and lower motor, usually the common etiologies are subacute combined degeneration of spinal cord due to B12 deficiency, copper deficiency, HIV infection, different hepatic disease, and adrenomyeloneuropathy. These are the common conditions where the combination of upper motor and lower motor we see. Now we have to come to the layer 2. First layer we have analyzed what type of fiber is involved, whether axonal, demyelinating, or large fiber, or small fiber, purely motor or purely sensory, like this. So now we will come to the layer 2. Layer 2 means what is the underlying pathophysiology, whether demyelinating, what are the etiology of demyelinating, what the etiology of axonal, or is there is a mixed clue. Very important, now we will come the layer 3 to identify the etiology, what are the etiological diagnosis. So here, so temporal course is very important. You have to take the history, whether it is acute onset, subacute onset, or chronic onset. Example of the acute is AIDP, vasculitis, porphyria. Subacute, that progress over 4 to 8 weeks. It is a different nutritional deficiency, malignancy, paraneoplastic syndrome. Or chronic, that progress about 8 weeks. Here the chronic inflammatory, that is the CIDP, different hereditary disease, toxin, diabetes, these are the common etiology. Next you have to inquire whether it is a relapsing course, and this happens in case of CIDP, porphyria, or there is a stepwise progression like mononeuritis multiplex, or it is a monophasic disease like the AIDP. Next, inquire whether there is any hereditary involvement. Hereditary involvement, how you can ensure that whether there is a very long history over decades, very slow progression, there is a similar history in the family, or sensory symptom is less, but positive, there is the presence of lot of foot deformity is there. If these are there, you think of the different hereditary condition. Or there is any occupational or toxic exposure, particularly in our country, lead, organophosphorus, the agriculture worker or those work in the different lead factory, they have a neuropathy because of the chronic exposure from the lead and organophosphorus. Or there is any drug exposure, substance abuse, or patient have any other medical history like diabetes, collagen vascular disease, infection, or different malignancy. So taking the history and examination proper, you have to identify what type of fiber is involved and what can be the possible etiology for this disease. So now we are coming back to the cases to come to the conclusion at the end of our approach, clinical approach. So case scenario was patient has weakness of the all 4 limbs, wasting, hypotonia, absent tendon reflex, sensory symptoms are present. So lesion at the level, it is a classical example of the lower motor neurological lesions. And from the history we have excluded, this is not a anterior hornsel disease or myoneural junction, myopathy, rotor plexus. So first case was a case of the peripheral nerve disease. When the peripheral nerve disease, then as this patient has a distal symmetrical distribution and decreased touch and pain sensation, and globe and stocking distribution is more, that going in more in favor of peripheral nerve disease rather than a polyradiculopathy. In polyradiculopathy, there will be more a root pain. Then whether it is a large fiber, case 1, large fiber or small fiber, in the case 1, the presence of weakness, impairment of the position, vibration sense suggests there is an involvement of the large fiber. And also, as there is a first case, there is a decreased touch and pain sensation that suggests there is an involvement of the small fiber. That means in the case 1, there is a both involvement of the large fiber and small fiber. So whether it was a first case was a case of demyelinating or axonal, patient has a lot of history of wasting and weakness and length dependent involvement, a pattern of involvement. So that means it was basically a case of axonal involvement is more than the demyelination. So common etiologies of this condition should be either diabetes, toxin, organophosphorus, arsenic, or drugs like metronidazole, vitamin B12 deficiency, paraproteinemia, hereditary, collagen vascular disease. So final diagnosis of first case was chronic sensory motor polyneuropathy involving both large and small fiber and predominantly axonopathy. So from this diagnosis, you have to search for the etiology and you have to treat accordingly. Some may be intractable symptom, but some cases, if you supplement, you can get a good result. So we are coming, if we come to the second case, the localization, there is a both upper motor and lower motor involvement, and patient has basically, this patient has a myeloneuropathy, predominantly large sensory fibers involved because of the predominantly the posterior column involvement, a Romberg sign positive, and also corticospinal tract was involved. That is why the plantar was extensor. So etiology of this condition, basically either HIV disease, vitamin B12 deficiency, and hepatitis disease. On investigation, this case was found to have a vitamin B12 deficiency, and first case found to be a diabetes. So provisional diagnosis was in the second case subacute combined degeneration due to vitamin B12 deficiency. So this is the clinical approach of a peripheral neuropathy, rather than blanketly giving some of the drug that can help or can minimize the pain sensation. Rather, we should go by your clinical skill to the depth of the examination, history and examination, so that we can perfectly localize the anatomical site of lesion and also the etiology, because many of the etiologies we can very easily can supplement or we can cure the disease, and there is no need of so many the pain relieving drugs, such as in the second case. So this is the, thank you, and this is the approach, whether you are internist or diabetologist, when the patient will come with a burning sensation, tingling, numbness, whatever may be positive and negative symptom, you must examine, take in detailed history so that you can come to a conclusion, site of lesion and particularly etiology. Thank you.
Hello. 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 Thank you. I think it was an excellent clinical discussion, and the presentation was most clinically oriented. And if you take diabetes as such, I think we have more than 1 lakh diabetes patients we have analyzed. And if you see the after the most common presentation will be asymptomatic, almost 50% of the patients. The next presentation will be the peripheral nerve symptoms, what we have seen in practice, because it has changed from over the years.
Diabetes can, from diabetes, all sorts of neuropathy is possible. It can be pure motor, it can be pure sensory, it can be combination, it can be mononeuritis, it can be polyneuritis. But yes, most common is asymptomatic, followed by only loss of vibration sense. So in diabetes patient, if there is minor symptom or asymptomatic, at least vibration sense should be done. That can be the earliest presentation when no modalities are involved, only the vibration sensation can be lost. And diabetes is one of the classical example of the dissociative anesthesia. That means vibration and joint position sense go by the same track. But only in diabetes, there may be joint positions is normal, but vibration may be lost. So this is a very important tuning fork. Nowadays, even the students when come to the class, hardly they keep the tuning fork, and we forget that art. But this can help you to identify the diabetic neuropathy at the earliest possible.
And one more point I want to make is, now if you see, we have to analyze vitamin B12 levels in most of our patients, because we have done one of the studies where almost more than 30% had vitamin B12 deficiency. And of course, with metformin therapy, definitely we should analyze vitamin B12. And if they are deficient, if you give vitamin B12, definitely we will have good response. And then the vitamin B12 levels, we have seen deficient in vegetarians. Recently, there was one article, even in non-vegetarians also, because they take non-vegetarian once a week or once 15 days, even their vitamin B12 deficiency has been seen. So definitely it's better to analyze vitamin B12 levels when we suspect vitamin B12 deficiency in our patients.
In India, 48% population is purely vegetarian. And on the top, what you told, they take very minimum non-veg food. Just by name, they are non-vegetarian. Maybe once in a week or once in a month, they take the non-veg food. So vitamin B12 deficiency, not only for the neuropathy, nowadays a lot of cases we are getting the pancytopenia. A lot of cases we are getting. So vitamin B12 deficiency awareness should be increased.
And even diabetes education is very important, because what we have seen, if you offload with the proper footwear, we can prevent most of the foot ulcers and amputations. That's also one of the message I wanted to give.
Thank you.
Any questions from the audience? Yeah.
Deficiency is already existing. So, and with the patient already taking metformin for a longer period of time, so there is no point in analyzing B12 in a patient. Unnecessary, it is a wastage of money. I mean, in a resource limited. If you want to evidence it, then it's a different story. Otherwise, we can supplement it.
Or you can do simple test, MCV and hemoglobin. These simple tests can be done. This is not very costly. We can see the macrocytes with the maturation defect or polychromasia, low hemoglobin. We can suspect that rather than doing routinely vitamin B12, it takes almost 2,000
peripheral smear itself, we can suspect.
Peripheral smear can indicate.
I think one more question from Professor Rajana.
We argue that non-vegetarians, they will get vitamin B12. but it is a water soluble vitamin. During the process of cooking, pressure cooker cooking, definitely it will be spoiled. So we have to take some raw vegetables. And for example, I am a strict vegetarian. How do I get vitamin B12? It must be in the form of supplements. Is water, milk we boil, vegetables we boil, and it is a water soluble vitamin. Definitely in that temperature, the pressure cooker temperature will be as high as 120 degrees centigrade. So definitely it will be, so we cannot say that non-vegetarian people, they get, vegetarians, they will not get. That argument, I think we have to question.
Thank you.
Okay. Thank you. If there are no questions, we will close the session. I want to thank Dr. Srinivas Murthy and the allied team for giving this opportunity. Thank you.
Thank you.
I thank
Thank you
Dr.
very much
Professor
to the
Srinivas
speakers and the
Murthy
chairperson.
for giving me the opportunity to chair the session. Thank you.
So we will request the chairperson and speaker to move to the selfie area.